Hi, everyone. Dr. Michael Miyazaki, and I'm glad you joined us because this is going to be a really good program we have tonight because we have another true endodontist, Dr. Ryan Walsh, and he's been doing some of these YouTube programs for us. So if you missed those, go back and check them out. They've been wildly popular. So I heard they're doing really well. And
Awesome.
Dr. Walsh, thank you very much for joining us.
Hey, Dr. Mike, thanks so much for having me on. Good to see you again.
So as a teaser, what are we going to be talking about today?
Let's talk about something a little contrary to what people think about endodontists. Let's talk about vital pulp therapy. Let's talk about how to save the pulp and save the tooth for some of these young people.
All right, so we're not taking the pulp out. We're going to leave it there.
Let's leave it in. Why not?
Okay,
We're pulp lovers, not pulp haters.
that's great. All right, go ahead and show us your case.
But yeah, I had a pretty fun case. I had this really cool 10-year-old. Not too many 10-year-olds walk into my office and tell me right out of the gate that they don't want nitrous and they don't want sedation because dentistry is a piece of cake. So so when you get that patient, life is good. I told him if all my adult patients were as good as you, my life would be a walk in the park. But he got referred over to me because his dentist did kind of a sedative type of filling for him and gave me a call and said, hey, Ryan, is there anything you can do for this short of just doing a root canal? He's only 10. Is there any way we can keep the pulp alive a little bit longer, maybe allow for a little bit further maturation of these roots? And, so sure. Yeah. I mean, as long as they're asymptomatic, as long as, all the cards fall into place, of course, there's a bunch of different things that we can do for him. And so when he was sitting in my chair, the first thing I'm thinking of here is diagnosis, right? I mean, you're you're crazy if you overlook diagnosis for vital pulp therapy cases because that, Dr. Mike, as you know, diagnosis is so key to the longevity of these cases. If they have a severe irreversible pulpitis or extensive symptoms, a lot of times it's better just to consider doing the root now rather than do a vital pulp case. But in this case, he was completely asymptomatic. He came in again telling me kind of what I wanted to hear for quite a mature 10-year-old. But really, this was just a decay proximity issue, not a symptoms issue. And so the decay got close to the nerve or pulp of the tooth. And in this case, why not? He's an asymptomatic child. Why not try to do as conservative treatment for him as we can, help prolong the life of the pulp of the tooth and get him on down the road? And sure, he may need a root canal at some point in time, but vital pulp therapy these days under the right conditions is really predictable. So why not give it a shot? So here are my pre-op films for this young fella. So this clinically, this is what it looks like. And a couple things to note here. First, you notice this IRM temporary filling kind of on the distal of the tooth. You also notice this little blue collar around the tooth there. And Dr. Mike, that's liquid dam. And in cases where the rubber dam seats well, but there might be a little bit of leakage going on, liquid dam is such an awesome way to seal these cases. It's easy to put on. You just flow it right around the tooth, give it a 20-second cure maybe, and you're all set. And it keeps things very well isolated. And then from there, I remove the IRM, and this is what you see. Going from the upper left to the upper right of your screen. Now we're seeing the remaining caries right over the pulp. And for cases like this, my primary goal or what I'm trying to achieve is to remove all the peripheral caries first. And that leaves me with these central or what I call circumpulpal caries. And once you're at that point, take a brand new diamond burr, and then you can excavate those circumpulpal caries. And that way you're not introducing additional bacteria into the pulp of the tooth and hopefully helping to prevent seeding bacteria further in. So at this point, you would use a brand new diamond burr and just remove all the caries. I don't want to say extension for prevention because I think that carries some connotations, but I want nice, clean dentin surface. A, for bonding, but B, for residual bacteria. And so this is the hemostasis all on its own. There's no hemostatic agent being used here. I just simply removed the circumpulpal caries. There were a couple pulp exposures, and so I removed any thin dentin bridge between them, and this is what it was. You can see it. The pulp here is it's behaving very well. It's not hyperemic. You're not seeing it bleed into the cavity. You're seeing it just kind of sit there and maintain itself. And so that's ideal. That's what I'm hoping for. In this particular case, The clinical symptoms and findings were what I was expecting to see based on the diagnosis here. Again, so kind of asymptomatic irreversible pulpitis, where that caries is just getting into the pulp of the tooth. And once we're at this point, well, then we're sitting pretty because the pulp's behaving itself. The patient is certainly behaving himself. We are ready to rock and roll. So at this point, now we can focus on the restorative aspect. So first and foremost, we have to think about the pulp. And in this case, this is such a perfect indication for regen putty. I mean, there's no better indication in my mind because you can take regen putty, it comes out of the syringe, you can roll it however you want. You can roll it into a little ball, you can even roll it into a hot dog, as you see here. And so I roll it into a hot dog on a glass slab and just take a small 3 to 5 millimeter segment. And I have it on a glick here. You can use a plugger or a spoon and just gently place it over the pulp tissue. Now, I don't want to compact it. I don't want to smush it into the pulp per se. I just want to place it over the pulp, or as one of my professors would say, I want to adapt it to the pulp space. And so there, just gently leave that little increment. I actually added another increment just to make sure I had full coverage across. And you want to extend it a couple millimeters beyond the margin of the pulp exposure to make sure that you're going to get a good seal. Now, one of the best things about this material is that it's going to take the moisture from the pulp tissue and from the surrounding dentin and set. That's one of the unique things about these bioactive materials is that they require moisture. They're hydrophilic, one of the few things in dentistry that want moisture. And so what better environment than right over the pulp? So that pulp is going to provide the moisture for this material to set, and it's going to harden up like medical grade Portland cement. And as you can see on the right side here, I've just used a spoon just to kind of contour the periphery and then just a moist cotton pellet just to get a nice smooth surface. And then that's it. That's literally all the magic right there. Place that in direct contact with the pulp. What that's going to do then is that's going to stimulate tertiary dentin formation. And from our histological studies and from our clinical studies, we know that we're going to get a nice thick layer of dentin formation immediately adjacent to this bioactive material. And what that'll do is that'll promote pulp survival. It's going to continue root development for this 10-year-old. It's going to still maintain most likely some thermal response. So in a few months or a few years, if I test this tooth with cold, he's going to feel that because the pulp's still alive. And we're trying to maintain that vitality. And once we get this covered, get a nice clean dentin surface, one of the other things that I love about regen is that it cleans up so easy. So in this particular area here, you can see that there's not a whole lot of white impregnated dentin beyond the actual margin of that pulp exposure. And that's one of the beautiful things about regen is that you can take a little cotton pellet or a little micro brush with a little water and just scrub the dentin and that material comes off. So it stays where it's needed, but easily cleans up where you're going to bond to dentin so you can get a much stronger adhesive bond. After I have the regen placed, I'll cover it with a glass ionomer. In this particular case, I knew I was going to cover it with a glass ionomer because I wanted to remove the liquid dam. And at that point, I knew there might be a little bit of saliva leakage at the depth of that restoration. So place the glass ionomer around to keep everything nice and sealed over the pulp. And once that's set, then you're ready to etch, prime, and bond, just like any other restoration that you're placing. So place a little etch, a regen bond, get the bioglass activity at the depth of that restoration, and then restore it with a flowable composite, or in this case, a dual cure composite to build the core. This young kiddo's planned for a stainless steel crown from the general dentist, so I wanted to get a nice contoured core and restoration. Check the occlusion to make sure he's not thumping down hard. That's what you can see the blue marks, just to make sure that between my treatment, the time he's able to get back with his dentist, that we're not seeing any adverse occlusal effects. And here's the post-op radiograph. You can see we have about a 3 millimeter thick layer of regen right over the pulp. It's not smushed into the pulp. It's just adapted to that exposure and a nicely contoured restoration. So hopefully that should set the general dentist up for a nice stainless steel crown, and even more importantly, set the patient up for good success moving on down the road with a nice healthy tooth.
Wow, it's pretty amazing. That's a great case.
I mean, sometimes these pulp treatments are just short and sweet.
Yeah.
Good isolation, good technique, and it's a win-win for both the doc and the patient.
Yeah. So let me ask you a couple questions because yeah, that's an amazing case. And yeah, I didn't see a file in the whole case. That's pretty amazing for an endodontist. So, one of some of the questions that I have, and probably some of those watching would have, is, when you took the decay out and you had that new sterile burr, did you just clean out the orifice where that decay was on the roof of the pulp, or did you go down into the pulp and actually get into any of that pulpal tissue?
Yeah, great question. So initially, I'm just cleaning off the decay and basically exposing the pulp. In this particular situation, the pulp behaved itself. In other words, I wasn't seeing a hyperemic pulp. So I didn't have to do anything else other than just remove the infected dentin. In a case where you're seeing some hyperemic pulp, it's okay to take that burr a little bit further and remove 2 to 3, maybe even 4 to 5 millimeters of the pulp tissue to get that pulp that's been exposed to the bacteria and is all hyperemic to get that out of the way. In some cases, I always caution my parents this that we may need to go to a quote unquote traditional pulpotomy and take it all the way to the chamber floor. And still, that's okay. There's no problem doing that. You kind of remove enough to where the pulp's going to not be hyperemic, going to kind of coagulate on its own within just a couple minutes. I'll use sodium hypochlorite directly over the pulp, not into, but over top of the pulp. And as long as it will maintain hemostasis, you're ready to go. So only remove as much as you need to. You don't have to uh, go really aggressive and remove a whole lot.
Okay. And then when you get to the stage and you've removed some of that, the roof of the pulp chamber, and you're looking down into the pulp area, could the reverse be true? What if it were, no blood at all? Do you then worry that's necrotic and you should just do the root
Mm.
canal instead? Is there an indication for that?
Sure. Yeah, absolutely. And again, this kind of goes back to the diagnosis at the very beginning that
Hmm.
if you're getting kind of an inconsistent pulp response, or sometimes your patients, especially young kids, 10 years old or so, don't really know always what you're asking for. So, yeah,
Hmm.
if you get inside and you see nothing and you just see cobwebs inside, yeah, then it's a necrotic pulp. And at that point, no pulpotomies can be done on a necrotic pulp because there's no pulp to otomy. So at that case, then yeah, we're moving toward a root canal at that point in time.
Okay, so that's great. So I think a couple points are you had really good isolation. That's so when you do expose the pulp tissue, it's not going to be contaminated by saliva or anything like that. You use a sterile burr. You didn't use a burr that you had cut through all the decay back in the bacteria with. You went to a sterile burr before you got in there. And then you place the regen, and this is the regen endo putty. And then,
Correct.
yeah, the regen endo putty is going to create alkaline environment there, which is going to help that tissue heal up because it's got the ability to do that. Would you use anything else, or do you just like that endo putty?
I mean, for these types of procedures, the putty to me is the best because it has enough body to it that you can place it over the defect, and it almost behaves like IRM. You can kind of mold it and sculpt it to whatever the defect is in your particular tooth. So I think the putties are ideal for this particular situation. And then on the backside, they clean up so well, so you're ready for your bonding right afterward. Just give it a little coating or a little cover with glass ionomer, and you're ready to go.
Cool. And then, oh, the last thing, I think you were saying that this pulp, was it irreversible pulpitis or was this case reversible pulpitis when you got in there?
So asymptomatic irreversible pulpitis. I mean, that's a fancy way to say that the decay was getting right into the pulp. And so in order to remove the decay, we had to expose the pulp. So once it's exposed, then it was became an irreversible pulpitis, but not in the symptomatic way we're conventionally used to thinking about it.
Okay, cool. No, that's great clarification. So this is a great case, and yeah, I would encourage our viewers to really think about doing this, where if you're close to the pulp and you're going to have a small exposure to go ahead and do this. And then could I ask one more question? What if you had gotten into this tooth and you had that thin roof over the pulp chamber, there was not an exposure? Would you recommend the doc then restore this, or would you recommend placing this regen endo putty like a little bit over that so you have the bioactivity in that over that thin roof? Any recommendations there?
Sure. You could do an indirect pulp cap exactly the same way that I'm showing you here, except there's a thin layer of dentin. In my experience in I think the endodontic literature would support this, that at least exposing the pulp, you're getting rid of another layer of bacteria between you and the pulp. And
Mm.
so, if we can get rid of that last bit of bacteria, we can stimulate that tertiary dentin formation very predictably with these types of bioceramic or bioactive putties. So, in my opinion, I'd rather remove that eggshell thin layer of dentin that we know is contaminated with bacteria. Just get that off and let the pulp do what it does best, and that's heal.
Cool. No, thank you very much. This is great information. I think when I go back to work, I'm going to be looking at this totally different. So no, Dr. Walsh, thank you very much for your time. I look forward to seeing you more on the program because we are going to have you as a guest presenter on a regular basis now. So I hope everyone's excited about that. I hear all the claps back there. Everyone wants to hear more of you.
Oh, I love it, Dr. Mike. Thank you so much again for the invite, and I look forward to discussing more cases just like this.
All right. No, thanks. So everybody, real quick, if you like this, hit the like button. If you want to make sure you don't miss any of Dr. Walsh, hit subscribe. We want more people to be involved because again, we're creating a community of like-minded individuals trying to do the very best for the patients. And I think you could take today's program as a great example of that. Great information, how to use products, how to be more successful and do better things for our patients. So thank you very much for watching. And Dr. Walsh, thank you very much.
Thanks, Dr. Mike.
Been great having you. Thank you. See everybody during the next episode.